Hello and welcome to a film review of the skull and sinus projections. I'm going to divide this presentation into two parts. We'll talk about the skull positioning first, and then in part two we'll discuss sinus positioning. Now, the skull projections that we're going to use or check off on in lab include the Townes, the PA, and the lateral. There are other skull projections. We are just not going to check off on them. So if you got an order for a skull projection that you weren't familiar with, you would look up, you would have a Bontrager at work. Most departments keep a couple copies. And you would look up that skull projection and utilize the information you already know, such as the positioning lines and the landmarks, to complete that exam. Skull projections are not that common anymore. A lot of our work is going to CT. So we're going to learn the basics, kind of the most common ones that you do, and you should be all set. Now, we're going to do these on the table, recumbent. The PA and the lateral skull can be done upright, but we are going to assume that this patient is recumbent. Okay, let's talk about the Townes first. Now, the Townes is actually considered an AP axial projection. So what does that mean? Well, AP tells us that the patient is supine, and axial tells us that we are using a tube angle. Remember, axial means a tube angle greater than 10 degrees along the long axis of the body. Now, this projection can be found on page 413 in Bontrager. And I want to caution you, when you are looking in Bontrager, chapter 11, the positioning section of the chapter is divided into skull, facial bone, and sinus. So I can do a Townes for the skull, but I can also do a Townes for facial bones. So be very careful when you're looking through the chapter that you're in fact looking at the correct exam. At the top of the page there's a long red bar, and in that bar it tells you, is this a skull projection, a facial bone projection, or a sinus projection? So just be mindful of that and just be careful. All right, for the Townes projection, we are using a 10 by 12 portrait, and we're going to utilize OML or IOML. Now, when do we use which line? Well, if you look at our model here, OML perpendicular to the image receptor is ideal, but many patients have difficulty flexing their neck or tucking their chin that much. If you have a patient with, a double chin, for example, or if you have a patient that maybe has arthritis in their neck and it's difficult for them to flex, getting OML perpendicular can be a challenge. If you can't get OML perpendicular to the image receptor, you can use IOML. That allows the patient to relax their chin a little bit, and it's just a little bit easier for some patients. If you use OML perpendicular, you can use a 30-degree caudal tube angle. You're going to center 2.5 inches above glabella. If you have to use IOML, you're going to use a 37-degree caudal tube angle. What does that tell me, by the way? That tells me that there's a 7-degree difference between the outer canthus and the bottom of the orbits. So just keep that in mind as well. We're going to use 20 mass at 80 kVp approximately. And how do we know we're correctly positioned? A couple things to look for. First of all, your petrous ridges should look symmetrical. Well, let's look at our image. This line right here is your left petrous ridge. This line right here is your right petrous ridge. You want the petrous ridges to be symmetrical. In other words, you don't want one to look higher than the other. That can indicate rotation and or tilt. So my petrous ridges here look really nice. Also, you want to see the dorsum sellae in the foramen magnum. So remember, the foramen magnum is that large hole at the base of our skull where the spinal cord passes. The dorsum sellae, remember, is the back of the sella turcica. So here, right here, I can see the dorsum sellae within the foramen magnum. Very nice. Okay, lastly, we want to make sure you see light on 3 sides of the skull. In other words, make sure you're not clipping any side of the skull. Notice we are clipping facial bones. When you are doing a skull projection, you do not need to include facial bones. You just need the actual skull or the actual cranium. So keep that in mind as well. Let's look at our next projection. It is a PAskull. So notice the patient is now prone. This is found on page 416 in Bontrager. You're still using a 10 by 12 portrait. This time you want to make sure OML is perpendicular to the image receptor. So when you watch my positioning videos, you'll notice that I like to use a pen. That pen helps me to make sure that my positioning line is in fact perpendicular. So I find that to be a handy trick. So you want to make sure OML is perpendicular and that you're centered on mid-sagittal plane. Your central ray is going to exit the glabella. So if you kind of follow this central ray down, you'll see that it's lined up with the glabella. So OML is perpendicular and you're exiting the glabella. You're using 18 mass at 80 kVp, and how do we know we're correctly positioned? Well, our petrous ridges should completely fill the orbits and superimpose the orbital region. So let's look at this here. So our orbit is right here, and then here is the right orbit. And see this line right here? This is my petrous ridge, and here's my right petrous ridge. Those petrous ridges should fill the orbits. They should line up with the top of the orbit. So actually, in this case, they could go up just a hair more. I want to show you an example of a repeatable error with a PAskull. Notice how low our petrous ridges are. This is absolutely repeatable. We need to raise the petrous ridges. They need to fill the orbits. That tells me that OML is not perpendicular to the image receptor. So how do I fix this? Well, if you want to raise the petrous ridges, you need to tuck the chin more or flex the neck, however you prefer to think about it. By dropping the chin, that will raise my petrous ridges. Okay, let's look at our third skull projection, and it is a lateral. So I apologize, I couldn't find a nice lateral skull without any of the labeling. But if you were curious, you can find the answers to the labeling on page 384 in your textbook. The positioning for this, for a lateral skull, is found on page 414. This time you're switching your image receptor to landscape. You want to center about an inch above EAM, and you can see that here. And you want IOML perpendicular to the table. I find that wording a little bit confusing. When I look at this IOML, to me it should be parallel to the table. But really and truly, when I do this position, I want to make sure that IOML isn't way up here. That would indicate that her neck is extended too much, or that IOML isn't way down here because then she'd be flexing too much. You really want it nice and straight and facing you. You can also use the interpupillary line to help you as well, and make sure that's nice and perpendicular to the table. This projection has no tube angle, and you'll use 8 mass at 80 kVp. Many times department protocols will indicate if you're doing a lateral skull, you do both laterals, right and left, because we know that whatever side is closest to the image receptor is going to have better detail. So if you're looking for a very subtle fracture or pathology, you'd want, both sides evaluated closest to the image receptor. How do we know we're correctly positioned? There's a couple things you can look for. First of all, look at the sella turcica. That is going to be this U shape right here. Now you know from looking at your actual skull model that the sella turcica is not just a horseshoe. It's an actual kind of little mini tunnel. And so if you're rotated or tilted, you will see both ends of that tunnel. A true, nice, perfect lateral will look just like a horseshoe or a U shape. So that's the first thing you can look at, no distortion in the sella turcica. The other thing you can look at is the orbital plates, and that's L. So you have an orbital plate above your right orbit, and you have an orbital plate above your left orbit. If there's no rotation or tilt, those orbital plates will line up perfectly. I'll show you an example in the sinus projection where the orbital plates are not lined up, and that indicates some tilt or rotation. So I'll show you that upcoming. The other thing you can look at is the mandible. Now, mandible is a facial bone. You do not need to include it on your skull radiograph. If you happen to capture it, it can be a good indicator of tilt or rotation as well. And again, I'll show you that in the sinus presentation. I'll show you an example of a mandible. Okay, so I can tell by looking at my cellatristica and looking at my orbital plates that this patient is in a beautiful true lateral. I have included all of the cranium. I'm clipping the mandible, but that's okay. That's a facial bone. So this is very nice. We're going to pause here. We'll pick up with sinus positioning in part 2.